left side of the lower jaw since 1 year. It was insidious in onset, gradually progressive to its current size of about 4 into 3 centimeters. It is not associated with pain. Patient also mentions of noticing an ulcer 5 months ago in the inner lower aspect of his left cheek, which was insidious in onset and gradually progressed to its present size of 2 into 3 centimeters. It was also not associated with pain. Patient gives history of having whitish patches in his mouth over the cheeks, floor of mouth, and over the tongue. In the negative history, there is no history of discharge or bleeding from the ulcer. There is no history of difficulty in opening of mouth. There is no history of difficulty protruding his tongue. No history of halitosis or excessive salivation. No history of loosening of teeth. No history of difficulty in speech or difficulty in swallowing food. No history of any other swellings in the neck. No history of cough, breathlessness, hemoptysis, jaundice, abdominal pain, or recent onset bone pain. No history of multiple sexual partners or IV drug abuse, and no history of loss of weight or appetite. Coming to the past history, patient has no history of diabetes mellitus, hypertension, bronchial asthma, tuberculosis, or ischemic heart disease. Patient before coming to Wenlock Hospital has gone to Father Muller Hospital with above complaints 1 month ago, where he underwent a biopsy and radiological investigation and was referred to Wenlock District Hospital for further management. Patient underwent extraction of 3 teeth about 3 years ago. Patient underwent a spine surgery following an accident 3 years ago. No history of any undergoing radiotherapy or chemotherapy. Family history, there is no history of oral malignancy in the family, and there are no history of any other malignancies in the family. Personal history, patient consumes mixed diet and has a normal appetite. Patient gets adequate sleep and has regular bowel and bladder habits. Patient has history of chewing betel quid since 30 years, about 10 times a day for 10 to 20 minutes each time, and mostly on his right side. He doesn't keep the quid in his mouth while sleeping. No history of alcohol abuse or smoking cigarettes. Coming to the history summary, a patient is a 63-year-old male with history of chewing betel quid since 30 years, who came with complaints of swelling over the left mandibular aspect since 1 year and painless ulcer over the left gingival-buccal ulcer since 4 to 5 months. He also has a history of having whitish patches over the oral cavity. No history of any other comorbidities. Patient has a history of undergoing teeth extraction and spine surgery 3 years ago.
Wait. We'll go back to the history, Robin. Go back, I think, Aditya. Chief complaint. Go back. Okay. Sir, Manoharan Sir, Muthukumaran Sir, Keshav has joined. Welcome, Keshav. Sunil Sir is there. Robin.
So as we have senior teachers in our midst for today's program, I'll be on the back side. I'll focus on the questions in the point section that YouTube, sir. Is that okay, sir?
Okay. That's the only thing is ulcer. He said 5 months. Swelling, he has told 1 year. So any comment on that, Samarth or Vishnu?
Yes, sir. Oral malignancy, especially of buccal mucosa, we see ulceration, and then if it infiltrates and with time, we usually it presents as a swelling. But in this case, we are seeing it as the patient first noticed the swelling and then the ulcer. But we think it's most likely because the patient has a poor oral hygiene and has not observed the left care for a while. And only when it got to the bigger size that he has noticed it. And then he has come to the hospital.
Okay, sir. Sunil Sir, Muthukumaran Sir, Manoharan Sir. Anything to comment this, or straight away go to the history of present illness?
Yes, sir. I am also wondering about why ulcer of short duration and swelling of 1 year duration. Same question for me also, sir.
So both are not correlating. Duration wise. Anyway.
Yeah, that's probably like he rightly told. Ulcer, he told probability is unnoticed. That is, otherwise chronology should be ulcer first, then swelling. Where it's reverse. That's why somebody sees this by first may think that it's a jaw tumor. Unless there is no history of ulcer, you may think suddenly as a jaw tumor. That's a point which you have to remember. I think
Probably patient didn't notice.
that's exactly the reason he has already told. Samarth had told that. So go to the next slide. So Muthukumaran sir, anything to comment this?
Now presenter to gradually progressing or the current size was not associated with pain. So you mentioned about the duration. First, the duration of the vital quid 30 years presented to.
Yes.
Okay.
It is okay, sir.
Okay, next slide. Throat size, it's not actually the pain, and there is no pain at all, Vishnu.
No, sir.
No.
Patient complains of no pain. Even when he has noticed the ulcer and the swelling, he says there has no pain.
So suppose pain develops, what are the causes for pain?
So, sir, in cases of buccal cancers or buccal mucosa cancers, if it affects the lingual nerve, it can cause ear pain, or if there could be any other ulcers like
Like radiating pain to the ear, that's the pain over the site. Eventually it may develop. What are the causes? They may develop.
It could be even after ulcers generally, or it could be, sir, it could, generally speaking, it could be even due to trauma, or if patient has sharp teeth, it could be because of that as well.
Okay.
Even secondary infection of an ulcer can also cause pain.
Second infection, and here if it is bone getting involved, periosteum getting involved, they develop pain. Understood?
Yes.
These are different reasons. Surprisingly, this patient still not have pain, even though it has come out. There is no pain to this patient. Usually they are painless to begin with. Eventually, it will become painful because of whatever the causes which we discussed. There's a point all students should remember.
The referred pain to ear is a common entity in oral cavity pain. That you have to remember.
Yeah,
referred pain to ear.
Referred pain to the to the ear.
Involvement of lingual nerve.
Yeah, lingual nerve and auriculotemporal nerve. That point is important. You have to remember. So we'll go to the next slide. Manoharan sir.
One clarification, sir.
Root canal involvement also.
Vishnu?
Yes, sir. Yes, sir.
You mentioned also, sir has already asked you questions on ulcer and the associated pain. You give history of whitish patches in the mouth, over the cheeks, floor of the mouth, and over the tongue. So basically, almost the whole of the oral cavity. I'm sure you know the definition of the oral cavity and the components of the oral cavity, except for the up to the retromolar, the posterior wall, 1/3 of the tongue, and the retromolar trigon. Just a simple question for revision for the students listening. What are the pre-cancerous lesions and what are the pre-cancerous conditions of the oral cavity?
Yeah,
just give us three.
That's the difference between conditions and
Yes. So generally, leukoplakia and erythroplakia are the main pre-malignant lesions that are present for oral cancers.
Precancerous lesions are different. Precancerous conditions are different.
Currently, it is they have put as a malignant, pre-malignant this one, but it is actually meanings are different. Like Robin rightly told, pre-malignant lesions and conditions are different. What is the difference?
Because in one, I'm sure it's very clearly written in Sir's book that the morphology, the structure is changed already, where it can be predisposed. That's a condition. Lesion, it has already been damaged. It is very high chances of it becoming. There are 3 plus 3. There are totally 9. It's very easy to remember it. The third type is discordant. Discordant, we are not bothered. Pre-cancers, you've said, just remember, very easy to remember cell. CC, chronic hyperplastic candidiasis, erythroplakia, and leukoplakia. Leukoplakia, you've said whitish patches. So I think some of the teachers here, so Keshav sir has also come to the meeting. So good evening, sir.
Hi.
Good evening, Keshav.
So so whitish patches, that's one thing. Then we have the thing. The pre-cancerous conditions are also 3. Which are they?
So it could be syphilitic glossitis.
Syphilis,
It could
yes,
be
very good.
chronic hyperplastic candidiasis.
No. The candidiasis is a precancerous lesion. It's not a precancerous condition. It's very easy to remember that also. Remember SOS. It's very easy.
Yes, and even
Syphilis is
plumber.
not very, syphilitic glossitis is not very common nowadays. So sideropenic dysphagia. Dysphagia. That's one. O, which is very common. I think we see it very. Yes, I think in this patient, if you can see inside, it looks like that.
Yes, so we can see
Oral submucosal fibrosis. Oh, exactly. And last you put syphilis because it's not very common. I'm sure you know. Yes, very good. And the last third variety, I think they ask it very commonly for exam, for theory exam. Yes, sir. Yes, sir. Anyone wants to ask questions? Yes.
Here you have mentioned that the patient gives history of having whitish patches in his mouth or cheeks and other things. But you have not mentioned the duration. Any complaint, you should have duration. Duration is important.
We asked him the duration, sir, but he mentions that it's been there since a long time and he doesn't remember since when. But more than the 1 year duration, he has the this thing.
Yes, that is very important. You see, it was already present before this lesion. That is very key. You should have mentioned that.
Yes.
One question.
Yes, sir.
Multiple lesions, isn't it? And it's not very focal also. So many lesions are there. So it is not possible that probably patient is not that much aware of it or something probably. But if you probe into each and every lesion, probably you will have some points to say which one started first, what led to. So seeing the lesion itself, it appears to be more chronic and diffuse. I mean, having multiple patches is there, ulcer is there, the extent is different, and so many things are there.
So, sir? Yes, sir. Sunil sir wanted to.
Yeah, what is the risk of malignancy in leukoplakia and what is the risk of malignancy in erythroplakia?
So, sir, leukoplakia, generally patients have 6 to 9 times more risk of getting oral cancers, but compared to erythroplakia, where there is around 10 to 15 times of oral cancer risk.
So, which is more?
Erythroplakia has higher incidence of forming into oral cancers.
You mean I couldn't follow leukoplakia or erythroplakia?
Erythroplakia.
So actually erythroplakia 95% of the time it is either carcinoma or carcinoma in situ or severe dysplasia.
That is more dangerous than the leukoplakia.
Yeah, so leukoplakia is only 7 to 17% risk of becoming malignant. So it is a less dangerous condition. Erythroplakia, almost always you need to do a biopsy.
Yeah, that is really high, very high potential erythroplakia. But luckily,
almost always cancer.
Yeah. Luckily, incidence of erythroplakia is rather less compared to the leukoplakia.
Yeah, correct.
So we'll go to the next slide, Robin. Next slide. Sir, anybody to comment? Halitosis. Why halitosis happens?
So, sir, the ulcer in the mouth can cause necrosis, and there could be even secondary infections in the ulcer, and they can cause halitosis and in this thing.
No, sir's question is very clear. Your first point is absolutely fine. We all agree. The tumor has necrosed. Now, we want to know 3 things that it releases. Very simple.
What it's a tumor necrosis. What it releases and causes the specific smell?
It releases 3 substances. What are they? That causes that bad odor.
What are the substances which causes the bad odor? Samarth.
Discharge is seen in the
what? Tumor necrosis or tumor releases something and that causes halitosis. What are they? Robin?
I think Robin, you can say he doesn't know.
You can tell the answer, Robin.
Sir, so one is mercaptan. I give them 3 clues, sir.
Yeah, it's a mercaptan mainly which causes
the halitosis.
Rotten smell, bad water.
Yes.
So
guys, please write down the questions and keep, because we are covering each topic. Just write down the question. It's just 3 things that causes that problem. Just find out the other 2. It's very easy.
Yes.
Loosening teeth. Why loosening teeth, you asked?
Sir, there is no history of loosening
Yeah, why?
even, but they could be history of loosening teeth.
Why you ask?
I said it could invade the mandible and cause loosening of teeth, sir.
Alveolus, it will mean alveolus and causes.
Alveolus.
Difficult in protruding.
What about
Yes, sir.
excessive salivation?
In oral cancer of tongue, we usually see excessive salivation. It's more common in oral cancers of tongue, sir. So we ask to see the extent of the oral cancer in this patient. We want to know whether excessive salivation was there.
Sriram Bhat, sir, any clarification on that?
What is the mechanism of excessive salivation? Is what
What is the mechanism of excessive salivation? What he said, Samarth?
I mentioned that in oral cancers of tongue, we see excessive salivation. So we want to know the extent of the cancer in this patient.
The question is why? Why excessive salivation?
No, it probably it irritates the.
What triggers salivation?
What triggers salivation? This way you can tell the answer.
Okay, it is basically it's a foreign body. Anything the moment you put something in the mouth, salivation is triggered. Okay, so the foreign body or it's a foreign body sensation in the mouth because of the ulcer or the tumor that is there. That stimulates the salivary glands to secrete saliva.
Yes,
So
sir.
it is a normal mechanism. Anything you put a food bolus in your body, in your mouth, you start salivating. So that is a normal mechanism that is enhanced in these patients.
Yes.
True. Any other reason, sir? Sunil, sir? That's a reason, I think.
No, I just want to hear from you people only because it's a very often asked question.
I know, that's true. So protruding his tongue because it involves tongue muscles. That's why they will have a ankylosing. Same thing because of the pterygoid muscle, mainly medial pterygoid is involved. Then they will have a twist muscle or difficulty in opening the mouth. Bleeding because vascularity and bleeding vessel get eroded because of the bleeding. That's the reason. Discharge again sloughs off and because of the discharge. Maybe infection still can cause the discharge. You should give us some reasons why these things happen. That's the only thing. Justifications you people have to give actually. You'll go to the next slide, sir. Sunil sir, Muthukumaran sir.
Yes, sir. Yes, sir.
Yeah.
Sir, before we go to the next slide, just to complete that one point, they've given no history of difficulty in opening of mouth. I assume you're talking about trismus?
Yes, sir.
Yes.
Yes.
On asking the patient whether he has difficulty in opening the mouth, he mentions no.
Yeah,
he has no
okay.
difficulty.
We just want to complete it for the sake of for everyone listening also. Simple questions there. What is the definition of trismus?
Trismus is the condition where the opening of the mouth due to the muscles involved.
Difficulty in normally opening the mouth. That's one. Very good. Causes of trismus? 3. What are the muscles involved in trismus? 4. What is the grading of trismus? That's all. Simple as that.
Masticator muscle, buccinator muscles involvement causes a trismus. So.
Masseter?
No, very muscle is involved. Specifically, which muscle?
Masseter and
Lateral pterygoid muscle.
Pterygoids?
Pterygoid,
pterygoids and buccinator muscle.
There's one more.
medial pterygoid.
When you do this, something else moves somewhere else. The temporalis.
So there are only few muscles: temporalis, medial pterygoid, lateral pterygoid, masseter, buccinator. Only these muscles are there in the oral cavity, usual functioning.
Yes.
You should know the WHO classification for trismus based on 2 classifications, that is interincisor and the mouth opening ones. Okay.
Yes.
Yeah, just 4 questions. I think you should be knowing that just to cover it for the. I'll type it in the YouTube channel also. Yes, sir, we can proceed, sir. Muthukumaran sir, any other questions?
Any other reason for difficulty in opening the mouth in such patients?
Right, sir. I wanted to ask the same question.
Oral submucous fibrosis causes difficulty in opening of mouth.
Why?
Okay.
What happens?
Repeated irritation causes fibrosis of the subbuccal mucosa and submucosal tissues, and this causes thickening in the submucosal tissue, and if it involves the large part of oral buccal mucosa, the complete opening is not possible because of the thickened buccal mucosa.
Yeah, there is the opening itself becomes small.
Yes.
Yes. Continue.
Mucosa is contracted.
Yes.
So, like ear pain, trismus is also a common finding in oral cavity malignancy. You should know the common causes for oral cavity. That is trismus.
Yeah,
Professor mentioned about muscle involvement and submucosal fibrosis. Suppose in parotid, involvement of the temporomandibular joint also can produce the same thing.
Yes, sir.
So, head and neck malignancy, we are worried about trismus. We are worried about ear pain. Apart from the clinical manifestation based on the site of malignancy. So, tongue malignancy clinical manifestation is different from buccal mucosa malignancy. So, based on the site, we have to elicit history.
Yes, sir.
Right. Why history of other swellings in the neck? Then why recent onset bone pain?
Sir, a history of other swellings in the neck to rule out any lymph node enlargements. And the other question, sir,
Bone pain. Which bone you are talking about?
generally we'll be thinking about mandibular bone as well, because there could be a invasion into the mandibular bone.
How does it involve the mandible?
And it can pass through the mandibular canal and cause invasion into the mandible.
So basically, that's where the oral cavity components come. The alveoli, the upper alveoli, lower alveoli. So it breaches into that, goes through the alveoli, and breaches into the ramus of the mandible. Yes, very good. Yeah.
It may be by direct invasion or through the subperiosteal lymphatics. The lymphatics are very common.
The dental pores. Yes, sir. Yes.
Yeah, by these two. That's okay. Then loss of weight, loss of appetite, only it is advanced if it is. They won't eat. That's why they will lose. They will lose weight. Why multiple sexual partners IV drug abuse? You asked.
Sir, to rule out HPV infections in this case. So because they are highly linked to oral cancer.
HPV virus is a very common etiological factor.
Name the number.
Yes, sir.
HPV, which one?
Which number causes oral malignancy?
HPV 16 more predisposed to cause oral.
For this one, I think HPV 16 causes more commonly, and that's why you are asked these things because and it is commonly HPV virus causes non-keratinizing squamous cell carcinoma for the reference purpose. Okay? That may not be necessary for you because it's for it's specified keratinizing, non-keratinizing. HPV causes mainly non-keratinizing. Next, we'll go to next slide, sir.
Yes, sir.
Slide. Aditya, next slide. Anything to add on, sir? Sunil sir or Muthukumaran sir, Manoharan sir? Possibly has told extraction of teeth, spine surgery. That is not.
I was waiting for this slide, sir. But previous history, he says there is no loss of tooth. Now here is underwent extraction of 3 teeth about 3 years.
No, like he said, loosening tooth, I think.
Yes, sir.
Okay. So dental extraction is there.
Why they have done the dental extraction? Have you asked?
Yes, sir. He had dental caries which had eroded deeper into the teeth.
Okay.
One more thing is there. 3 years back, he had a trauma. Is it due to trauma or something else?
He mentioned that he went an accident, sir.
Not related.
What is the site?
Whether he had a
Whether the extraction was at the same site. See, it is more important whether the extraction was at the same site or different. If it is in the upper jaw on the opposite side, is totally different. No?
That's very relevant. Keshav has pointed, very important. Whether the same place where current problem is there, that the teeth are extracted, or different place. Have you asked which
Yes, sir. On the same side of the same lower jaw.
That is very significant, no? Then probably they may have overseen that.
Absolutely. You might have had, you must start at that point of time only. You might have not noticed by the patient and also probably. Just we are not telling anybody is wrong, but this might have happened. It's very important actually. Okay, same side other are not that see which teeth they are removed. That detail that history is very relevant this should be mentioned, I think. So it's absolutely right. I think that's a very important point. So, sir, will anything next? We'll go to the next slide.
Yes, sir.
Yes.
Okay, next slide.
Vishnu, any reason particularly you asked for that no history of radiation in the past? Any particular reason with the swelling? Any particular reason you have asked?
Anything you wanted to keep in mind and ask just like because might have undergone treatment for carcinoma cheek or something.
Because usually past history, you have mentioned everything about medical history and surgical history, extractions, we agree. But that is an unusual past history. Anything out of the norm?
Anything you wanted to keep in mind and
Sir has given clue.
The patient already went to another hospital for the same complaints. We want to know if any treatment plan was whether he underwent chemotherapy or radiotherapy over there.
No, radiotherapy. We want to know about radiotherapy. Is it possible? Like we want to know, is it possible that post radiotherapy or chemotherapy, that patient has developed a swelling there with pain?
Post radiotherapy, jaw tumors, jaw swellings are seen.
something like that. Robin, you can tell the answer to them.
Is it possible that maybe we can think of osteoradionecrosis?
Yes.
Is it possible?
But that was very, very painful. And usually we'll have a edema there, discharging sinus.
Yes. It's a very, it was a dreaded complication. Nowadays, we don't see it apparently according to the literature because of very high-tech radio methods. But we used to see it in the old days. Yeah. Be very careful when you mention this because examiners will pounce on you.
So you should remember there is an entity called osteoradionecrosis, which
Sir,
is not that common because of the good technical methods of radiotherapy. Okay?
You should know what it is.
Yes.
You must know what it is. So that is they put the family tree, no oral malignancy in the family. Do you think oral malignancy runs in the family?
So, sir, it's possible because oral malignancy, especially in this case, if it's linked with P53 gene, some kinds of P53 gene mutations can go through families. Sir.
Commonly, it is a
yes, sir. Very rare for family inheritance, but generally it is a spontaneous mutation.
Any idea about that, sir? Muthukumaran sir, Sunil, Robin, Manoharan sir, whether it runs in family? I don't think
it is not family. It is an environmentally induced one. No,
he's an environmentally induced.
Using this agent for 30 years.
Yeah, that's a right word. I think environmentally induced disease. It is the proper word sir has told. That word is very clear. It gives a very clear idea. It's environment induced malignancy actually. So next slide. So personality chewing battle quid, that's very important. Why this quid is important? What that quid means?
So, sir, the fetal quid is generally is something that they take with, which is a combination of leaf, a betel nut, which also known as areca nut, slaked lime, and a tobacco. And these are generally kept in the buccal mucosa, and it is left there for some time, so that there is a the patient is
Quid is kept in the gingivobuccal sulcus. They keep it in the end. Usually, the people who use for night driving keep them all awake.
Yes, the drivers, night driver, they keep. That's the right thing, I think. Yeah, that's true.
Quid should be placed in one place; it should not move. So
and also work security people, watchmen, night watchmen. So they keep the quid in the mouth so that they'll be very alert. They won't sleep. I think that's a very good point. Sir has told actually. Who use the quid commonly? Night the work. Okay. So we'll go to the next slide.
Vishnu, sir, just a point to correct. Vishnu,
yes,
in the textbook, there's a difference. I think it's there in the Bailey also and in Sir's book. You should know the difference between the pan masala that is being sold out here and the betel quid that's in Kerala. We usually ask our students this common question: the components of the substance. When it comes to pan masala, that leaf is not there because the powdered form with all the components. The other thing, the beetle quid, as you rightly said, is the beetle leaf.
Beetle leaf is there, yeah.
Beetle leaf, you have the beetle nut in it. You have slaked lime, which is a very dangerous component. Then you have the areca. That is very much. You have catechu. And you have tobacco. There are 6 components which is coming in this. Of the 6 components, which is the most carcinogenic agent in this? Which is the most carcinogenic?
So, sir, in these agents, the most carcinogenic, I would say, is the areca nut, sir.
It is the tobacco. Sir,
and,
is it the tobacco?
yes.
Simply tobacco in any form.
Yes, tobacco in any form. Why do you think pan masala is banned now? Tobacco in any form is banned. Okay, that is the most carcinogenic agent. Second,
Tobacco is more.
the areca nut. Yes, the areca nut is also dangerous. But what are the 2 substances released from that nut?
So, sir, it releases something called ericotin, which is
it's arecolin. It's arecolin.
sorry, ericolin and tannin, sir.
Yes, these are the 2 things that are being released, and they have 2 different functions, which causes the first change before it comes to carcinoma, which is submucosal fibrosis, like what Sunil Sir already asked you. It's very easy to remember this. It starts with that, with the fibrosis. That's because arecolin, that causes stimulation and proliferation of fibroblasts and the collagen synthesis. The tannin is very scary. What happens is when there is stimulation of collagen, this guy stabilizes the collagen. So what happens is the collagenase which is produced cannot destroy it. So there is fibrosis.
Yeah.
These are the 2 things. Can you give us what is the specialty of this catechu? Why do we have 6 substances, components in this? What is special about? Have you ever seen roadside? I've seen in Mangalore when I came to see SRB Sir. The roadside in the masala. They do something.
Common in South Kerala and North Kerala. It's very common, mixed up.
Have you?
And again, tobacco individually is carcinogenic. Other things are probably in combination. Probably not that carcinogenic.
It's a combination. Yes.
So most dangerous is tobacco. Then combination is always like 6 components, definitely, because they help each other to aggravate the condition.
They are the word Sir uses is synergistic. Yeah. The Vishnu, the catechu's characteristic finding is actually it comes from the acacia tree. It's the only use for it. Actually, it is the only good thing which is in all these components. Unfortunately, like Sir said, because beetle nut, areca nut, tobacco, slaked lime, all these guys come and have a synergistic effect.
Yeah, that's what
it destroys the good effect of catechu. Releases some good substance. It was used in Ayurveda before. The reason these guys use it now is because it gives the red color to the pan. Don't you remember Amitabh Bachchan spits it out, the red color comes.
Right, like Robin rightly told you. In Mangalore, even hotel outside this catechu.
Yes, that's the only thing. It gives the color to the pan. That's it.
One more combination you can think in terms of Sir mentioned about synergism.
Synergism. You have mentioned no history of alcohol abuse. So alcohol is it's one of the 6 S's to remember for students. You have spicy food, which is there almost our South India and North India. It is there. You have spirits, which you have mentioned as alcohol abuse. You have smoking, which you have also used. These are the 3 common things that we always see. Then you have simple things. If the patient comes with ulcer, sharp tooth, sharpness. Yes. Once that goes, if it gets infected more than 2 to 15 days, you have sepsis. And the last S is syphilis, which we generally don't see nowadays because it's a civilized world, so it's not civilized world anymore. These are 6 S's, it's very easy. So the synergism, the S is the catch here. Yes, right?
Yes. 6 you have to remember. It's very common asked question to discuss.
Yes, thank you.
Next slide.
So you can add, sir, but the sensation what it gives. Some books it is given. The stinking is add on one more a low grade stinging burning sensation which keeps them awake. This is the only reason they use.
Yes. Summary, yes, sir. Summary. He has already told whatever the things. Already Keshav has pointed. Tooth extraction is very important. Others also, Muthukumaran Sir, Sunil Sir, Manohar Sir, Robin also discuss these points. Swelling in since 1 year, something less. What is summary history wise? What it could be? he has not mentioned whether you need to mention at this juncture or not. Just what's your opinion, sir? Muthukumaran, sir. Sometimes in the history summary they will tell probably this is this. Whether they should tell or not, they're sufficient in this summary. I think Keshav can tell or Sunil, Robin, Manoharan, sir. Sometimes they get confused whether to tell provisional possible diagnosis.
Sir rightly said that teeth extraction 3 years ago, the same affected that is significant.
Yes, sir.
So I think that could come.
They need not mention provisional diagnosis at this juncture, I think. If they mention also, it's okay, but what they suspect, they can mention.
No, definitely, if they suspect a malignancy, ruling out malignancy should be a first concern. So, you can tell that I'm more worried that it could be a malignancy. Definitely, you could say that the clinical presentation is more in favor of a malignant lesion.
Yeah, definitely they can mention that. Probably it is Carcinoma Buccal Mucosa. Presenting what stage also they need not mention, but probably patient is having Carcinoma Buccal. That's what thinking they can mention.
Especially if the lesion is very obvious. This is hidden inside the cheek. If it is fungating outside and all, it is easier to. It's probably better. They can comment that it is possible malignancy.
We'll go to the examination, Manoharan, sir.
Yes, sir.
Yes, sir.
Next slide. Samarth, go ahead.
Yes, sir. General physical examination. Consent was taken and patient was examined in a well-lit room. Patient is conscious, cooperative, and well-oriented to time, place, person. Patient is moderately built and nourished. Height was 1.69 meters, weight was 61 kgs, and his BMI was 21.35 kg per meter square. His pulse rate was 78 beats per minute, measured on right radial artery. A regular rhythm, normal volume, character, and normal condition of vessel wall, and peripheral pulse were normal. His blood pressure was 126/72 millimeters of mercury, measured on right arm in supine position. Respiratory rate was 14 cycles per minute, and patient was afebrile at the time of examination. No signs of pallor, icterus, sinuses, clubbing, or edema were seen. Can I have the next slide? These are the clinical pictures of photographs. Next slide, please. On local examination, on inspection, we see that facial symmetry is distorted due to the swelling present over the left mandibular aspect. Size 4 into 3 centimeters. It is globular in shape, it is well defined, and it has irregular margins. And skin over the swelling appears normal. Next slide. Lips and commissures appeared normal. Mouth opening was restricted with inter-incisional distance of 2.8 centimeters, which is indicative of grade 2 trismus. Next slide, please. An ulcerative growth of 2 into 2.5 centimeter in size is noted in the left gingival buccal sulci, lower left gingival buccal sulci, extending from 3 centimeter posterior to left commissure of lip and up to the level of second molar. The ulcer was oval in shape, had everted edges, and had slough present, necrotic slough present on the floor. Leukoplakic patches were seen surrounding the ulcer and also over the floor of the mouth and left side of the tongue. Whitish bands were seen over the buccal mucosa. Next slide, please. Poor oral hygiene noted with the presence of tobacco-stained teeth and no sharp teeth or loose teeth were seen. Tongue appeared normal, was centered on protrusion, and all the movements of tongue were normal. Gums were normal, floor of the mouth was normal. Retromolar trigone appears normal. Hard and soft palates were normal. Tonsillar fillers appeared normal, and uvula was central. And on inspection, no apparent swelling in the neck. Next slide. On palpation, there was no local rise in temperature, no tenderness over the swelling or the ulcer. All inspector findings were confirmed. Swelling present over the left mandibular region of 4 into 3 centimeters in size. It was globular in shape, had irregular surface. It was firm in consistency, and it was the swelling was immobile and showed fixity to underlying mandible. Next slide, please. Ulcerative growth of size 2 into 2.5 centimeter in size is felt in the left lower gingival buccal sulci. It had everted edges, irregular margins, necrotic slough over the floor. Buccal mucosa and mandible were the ulcer base, and it showed fixity to the adjacent mandible and showed integration of about 0.5 centimeters surrounding the ulcer. The ulcer did not bleed untouched. Next slide, please. On bidigital palpation of mandible, thickness of the left side of the mandible is felt. No tenderness was present on palpating mandible. No loose teeth were felt. Gums were normal. Tongue is normal. Close of the mouth is normal. Head and soft palates are hard and soft palates are normal. Sorry for the spelling mistake. Movements of temporomandibular joint are normal. Next slide. No cervical lymphadenopathy was present. No LR lymph others. Cranial nerve examination of 5th, 9th, 10th, 11th, 12th nerves were normal on both sides. Spine was non-tender. Paraspinal spasms were absent, and all the movements of the spine were normal. Next slide, please. On system examination, respiratory system, normal vesicular breath sounds heard over all the lung areas. No added sounds. No evidence of bronchopneumonia or lung masses noted. Cardiovascular system, S1 and S2 were heard. No murmurs. On per abdomen examination, there was no jaundice, no tender hepatomegaly, no free fluid, and no an abdomen is soft and non-tender. Central nervous system, there is no focal neurological deficit. Next summary: a 63-year-old male came with history of chewing bed liquid for 30 years. Came with swelling of left mandibular aspect since 1 year, and painless ulcerative growth or left gingival buccal sulci since 4 to 5 months. And he also has a history of leukoplakic patches over the oral cavity. On examination, a firm immobile swelling is present over the left mandibular aspect and grade 2 Christmas stain. And then indurated fixed ulcerative growth is noted over the left gingival buccal sulci, which had everted edges and irregular margins. Mandibular thickening is present on the affected side, and no evidence of cervical lymphadenopathy is present.
Next slide.
Provisional diagnosis: locally advanced carcinoma of left gingival buccal sulci. Staging is CT4A N0M0, which indicates stage 4 oral malignancy. For further accurate staging, we need depth of invasion and external node extension, which has to be assessed by image.
We'll quickly go to the examination. We'll go to the infection and go back to the slide, Aditya. Okay. Go back. Next. Anything general examination? We'll go to the examination, Robin. Okay. Next. Next slide, Aditya. Okay. Sir, Muthukumaran Sir or Sunil Sir, Robin, Keshav.
Sir, skin over the swelling is not normal. It looks red from the picture. I don't know.
It is actually
going to form an orocutaneous fistula in a couple of days.
Skin is not normal actually. On look, on palpation, I couldn't recollect.
And what else is there in the platysma?
Can
you see? Already looks like the platysma is getting, pulled up.
See that right upper slide shows very clearly skin is not normal. Samarth. Definitely, other areas skin is definitely photo not normal.
It's already invaded, I think.
Skin edema is there, skin changes are there, and if platysma sign is probably visible, I think. That is the okay. So
then what more?
I think skin over the swelling normal. Looking at this only, I think photos are very clear. I think Keshav Sir, Sunil and Muthukumaran Sir, I think Manoharan. That's not normal skin. There is skin edema definitely.
Definitely.
Samarth.
Yes, sir.
Visible abilities. And this is a platysma sign is probably visible. That's what Keshav pointed out. Surely you need to consider that one.
Here, you mentioned about the size of the swelling, 4 into 3 centimeter, globular in shape. Always you have to mention the extent of the swelling. We can get an idea whether the swelling is extending below the mandible or not, extending onto the neck or not. That you can explain.
Crossing the midline or not.
Extent you have to tell.
Swelling
and
absolutely.
Extent is important. We will get an idea.
That's the most important thing.
Most important thing.
Samarth.
Yes.
You have not
Everything confined to above the mandible level, or is it extending onto the neck level? You will get an idea. If you tell the extent.
On the neck level, but it does not cross the midline.
Okay. Crossing the midline extension, sir, is absolutely right. He has pointed out. Extension is very, very important in this. Even ulcer for and swelling also. That makes a lot of things to the patient, and our findings make clear difference as a clinical assessment. It's important point all should remember. Extension is a basic thing actually. It should be mentioned always. Remember. So we'll go to the next slide. Mouth opening restricted. That is probably okay. I think this much. We'll go to the next slide. Ulcerative, this one shape, reverted edges, fluff, he said. Look at the patches, he has told whitish bands. So what is that whitish bands? Any comments, sir? Sunil,
sir, whitish bands were seen over the buccal mucosa. I think those are patches of submucosal fibrosis.
Mobile labs, correct. I think. So any comments, sir? This slide, Sunil, sir?
So you were saying
here also
the size of the cell inside the oral cavity. What is the size you mentioned inside the oral cavity?
The size of the ulcer, sir?
Yeah.
It is almost a centimeter from the third molar, away from the third molar, and then it had almost 3 centimeters in front of the anterior part of the ulcer. So there was, and the ulcer itself was about 2 centimeters in length.
Okay, I think.
But the swelling which you are palpating from outside is the same swelling. You are palpating from inside.
Yes, sir. The swelling appears to be coming from the ulcer, sir. It is below the ulcer. Nearby area of the ulcer, on palpation, we feel it is thickened, sir, but the ulcer itself is not invading the entire area of that left.
No, you said that the ulcer is around 2 centimeters, and then there is an induration of 1 centimeter all around.
There's a set on palpation. How do you know this is only 2 centimeter size, or it look actually it will look bigger than actual? Have you measured?
Yes, I measured it by the finger. Like I placed my finger and then compared it.
You can put finger and then you can measure actually by the finger.
But you should mention how exactly it goes from the cheek to the gingiolabral sulcus, and then what happens? Where does it go into the mandible?
Here also, extent is incomplete
from that place.
Extent.
Yes. All over, you have not mentioned anything about that ulcer going towards the mandible
and the maxilla.
Very important.
It's going into even though you have palpation, he has mentioned that it is fixed to the mandible, I think.
No, but sir, he has not mentioned what exactly, because if the ulcer is invading through the mandible, because the teeth were extracted, so there must be sockets that are empty.
And what is that extracted areas? So that point we should mention.
Presence or absence of teeth is not mentioned, sir, near the ulcer. The Gingiva buccal sulcus he has commented. Whether the teeth is there around the ulcer, whether teeth is present or absent.
What is the anterior limit of the ulcer? How many centimeters from the commission?
3 centimeters.
Midline.
Right. What is the posterior limit?
Posterior, it is up to the level of second molar, which I compared with the other side.
What is the upper limit?
Upper limit, it did not extend upwards. It is lying in the left gingival buccal sulci. The left buccal mucosa is still normal.
Lower limit?
Lower depth is.
That is a Samarth. That is important because again upper extension, lower extension, anterior extension, posterior extension.
Yes.
That gives a lot of information. So like again, Sir has mentioned, extension is very, very important. Inside lesion, outside lesion. That gives a very proper, that's a very important clinical assessment.
As it reaches the mandible through the roots of the canal, root canal, or
the roots of the teeth are not appreciable anymore, sir, but because of the slough, but the ulcer appears to be involving from the side of the mandible, and
earlier you have commented. Earlier you have said that there is loss of teeth 3 years before at the same side. So you can tell whether exactly there is teeth are at present near the ulcer or not.
But teeth were absent near the ulcer.
And that is important. Now we are not mentioned at all.
Yes.
You have already committed in the statement. 3 years back it was on the same page that we discussed and we found out. Now the absence of the near the apertic ulcer, gingiva buccal sulcus involvement is there. Teeth is absent now. How many teeth is? How many are absent?
Actually, all the 3 molars and 1 premolar are absent on the side.
That is the extensive answer. That is the route through which the mandible has been involved.
Yes.
Yes, sir.
Why you are not mentioning anything about the teeth at all?
Yes.
First line itself says left gingival sulcus. And if star asked from anteriorly how far, posteriorly how far, and all that we are. Depth is what abutting. The next structure which is abutting is water. The root canal and the teeth. So that is missing now.
Yes, sir.
Yes, sir.
So the ulcer is extending into that up to that level or not?
Yes, sir. Ulcer is extending to the side of mandible up till the root of the teeth,
But
but they're not there.
That is important now.
Yes.
Yes.
Extent, I'll mention.
A clinical examination of oral cavity malignancy, we have two aims: to confirm the diagnosis of malignancy and to rule out or confirm the involvement of adjacent structures.
Yes.
By looking at the picture, I can say we are suspecting involvement of mandible, obvious.
Yes.
Yes, sir.
Maxilla is free because it is not extending up to the upper part.
Because upper figure you can make out very clearly. That's the
Very
point.
clearly. So maxilla involvement is ruled out. But clinically, we are suspecting mandibular involvement.
Yes.
Commissure is not involved. Something like that, you will get an idea about the adjacent structure involvement clinically. That will be
Yes, sir.
confirmed by your investigation.
Yes.
Based on the investigation, it will be managed. So clinical examination must be complete to confirm or rule out adjacent structure involvement. Very important.
Yes, sir.
Simple.
So that is important. So extension and this one. Keshav, anything to comment?
Yeah, I just want to know whether you know this. Suppose it's a T4 lesion, right? It is one structure lesion going to adjacent structure. Now, whether it's a CA cheek going towards the mandible is the same as tumor on the mandible going towards the cheek. Is the T4 the same? I hope you understood.
Yes, sir.
Or is
Only
there
the
a
cortical
difference in-
invasion of buccal mucosal cancer is, we did not consider it as T4 lesion.
Sorry? No,
In
no.
a-
Any oral malignancy, when one structure malignancy traverses the boundary, goes to the other structure, it becomes T4, irrespective of the size.
Yes.
Yes.
So, what I mean is whether tumor coming from the mandible side to the cheek is the same as tumors from the cheek coming to the mandible. Is it the same or different?
Different. What's the difference
Jaw
between the jaw
tumor is
tumor
different.
attended to the mucosa, mucosal malignancy attended to the jaw? What's the difference? How to differentiate? That's what exactly Keshav.
Is there any difference, or whether it is important to know that this thing for the patient?
Yeah, that's understood. No, if suppose there is no lesion in the mucosa.
Okay, let me just tell you, because different types of tumors have got some have got better prognosis compared to the other. So if it's a T4 from the cheek, going from the cheek towards the mandible, it has got a better prognosis than from a tumor arising from mandible going on to the cheek.
Yes.
So you should know, okay, because when the patient comes to T4, he may not be able to tell which it is, but it is better to know that there is a difference in the prognosis. So the treatment outcomes differ. Okay,
Especially in this case, because he said for the last 1 year there is swelling, but the ulceration occurred only recently.
Yeah, that's a
And also there is absence of lymph nodes.
So chronology is a different reverse actually. So that's important point actually.
So it is just for you to tell the patient, okay, this is a bad disease, this is not a bad disease. At least even for you to know that what exactly you're dealing with.
Yeah, that's why we have to think other way also, reverse order. Jaw tumor going to the mucosa. It's unlikely this patient, the mucosal tumor, is unnoticed probably. Still you have to think of, because he presented the swelling in the jaw. That's what the patient is worried. He is not much worried about the mucosal lesion because it's painless.
Yes.
There's a little different in the presentation in this patient. A lot of difference in the presentation. There are no lymph nodes also in this patient. What you said. So all those things are the very surprise presentation as far as oral malignancy is considered. Such a big lesion, no lymph node. It's a painless. Still, it is painless. Very uncommon thing in this lesion. That's why. Still, it is commercial carcinoma, but it's uncommon. Uncommon presentations actually. So we'll go to the next slide. Next slide.
What are the different cancers that come under stage 4?
Stage 4, there's T4A and stage 4 or T4, sir?
T4.
Stage 4. You said it is stage 4 now.
T4. So do you?
T4 cancers are stage 4 cancers, but in T4 we see T4A and T4B. In T4A, it's locally advanced. The mandibular invasion or invasion of floor of mouth is seen. In T4B, we see invasion of more important structures like base of skull or the involvement of retromolar trigone we see in T4B.
Okay, T4 adjacent lesion. Anyway, you said it is a T4 actually, no?
T4A is what I mentioned in this final diagnosis.
No, I'm asking if it is not T4, it is T3. Can this be stage 4? Supposing the T4 was not there, it was only T3. Can it still be stage 4? In other words, what all things come under stage 4 in oral cancer?
If T3 plus the signs of external invasion and metastasis, it comes under T4. So,
So specifically, you have to say which all T, N, and M will come under stage 4.
Yes.
M1 comes
normally, why I'm asking is normally if any other cancer, generally it is only M1 which comes under stage 4.
I'm not.
What, even M0 can be stage 4 if it is M2. Understood, no?
Yeah, even M2, M3, all these are stage 4 only.
Stage 4 only.
In oral cancer.
Even T1, N2 is stage 4. M0, stage 4.
Yes. So that's what I was asking. Because you said stage 4, it is correct. But then.
No, that's what Sunil Sir wants to highlight. What exactly you want to know, or people know, understood, no? So, nodal, this one is important.
Like that. You must know what are the things which come under stage 4.
Yes.
Right. Continue.
We'll go to the no apparent swellings in the neck. That's probably for this one, tonsillar fillers, he said, uvula, floor of the mouth, he said, retromolar trigone, he said. So, because of time, we are not discussing, but you should know about the boundaries of retromolar trigone. What is the significance of involvement of retromolar trigone? What is the significance?
It involves the ascending ramus and it might involve the temporomandibular joint also. So, the management changes.
What's the significance of that?
And retromolar trigone as lymphatics which directly communicate with the oropharyngeal pharyngeal lymphatics.
Plexus.
Pharyngeal plexus. So it's a more severe form of.
It's difficult to operate actually. We will not be able to take complete clearance. So we'll go to the next slide, Robin, Sir, Manoharan Sir. Okay. Palpation. Anything to comment on this palpation? He said consistency is far more hard. I was actually I examined this patient. I felt it is hard, but I didn't correct. I gone through slides. I done some corrections here. Spelling mistake, all those things I have done. But findings I have not changed because we'll have a discussion with that. I felt it is a hard swelling. They have told firm and irregular surface is irregular. So any comment on that? It's okay to tell irregular surface.
Margins, borders are irregular, regular. We usually mention surfaces are
uneven or nodular. They'll say smooth, nodular.
Smooth, nodular, lobular. Yes.
Lobular will tell. So use proper words. No, this.
Yes.
Always put it. Yes. That is because usually mandible comes out. There is soft tissue in front. So usually it is smooth.
Consistency, because you are telling it's almost it's involving the mandible directly. So if it is hard in one area and it is firm in another area, it is difficult to tell. Then there is a clear difference between the two areas, no?
And you said ulcer is indurated. Indurated ulcer, when it comes out like this, it should be hard actually. So if you say it is firm, you should give some justification. It's a immobile fistula underlying mandible, all those things are definitely accepted.
Immobility.
To the mandible, he's told that he has committed properly. Yeah. So next.
Swelling, you have to mention always whether it is well-defined or ill-defined. That is important.
He mentioned it is well-defined.
Well-defined.
Yes.
He's well-defined. He has mentioned, I think. Well-defined.
Yeah, he's mentioned.
well defined as
Very
mentioned.
correct.
Next slide. Okay, again, same ulcer is fixed to induration here mentioned 2.5 and surrounding it. It did not bleed on touch, slough there, irregular margin. Everted edges comes on, okay. Indurated edge, you can tell. Everted edge is the infiltrate finding, actually, basically. Anything to comment on this? Things are okay, I think, except indurated edge, you have to tell.
Yes.
Yes.
Version is mainly infiltrate finding. So, next slide.
Whether tender or not.
Also,
Non-tender.
Swelling and ulcer, both are non-tender, is it?
yes,
Yes.
sir, both are tender.
Yeah, both.
Both are non. No tenderness present on the bilateral palpation. That's a very surprise thing, actually. No loose teeth felt, gums are normal, tongue is normal.
No, why gums are normal?
Yeah, gums are normal. How it is? Because it is gone to the gum, no? In the left
It
side.
is arising from the gum or other way around? You know, anyway, it is involving gums, no?
At least you can tell gums in the remaining part are normal.
Comes in the remaining part.
Yeah,
Yes.
that's okay. But then you must say the rest of the area, the gums are normal. Yeah, but here the gum is directly involved.
Yeah, generalizing statement gums are normal because the gums are involved here. Understood? No.
Yes, sir.
So you specify where exactly it is normal. Otherwise, it goes wrong actually. Movements of temporal.
No, it's not clear from the picture, but looks like the tongue is also involved from the picture that you're showing.
That is
Tongue is involved. Picture-wise. Whether it's a leukoplakia or
That's a leukoplakia.
No, it is not leukoplakia. You can see the ulcer also there. Otherwise, you should have shown the tongue protruded. Then you would know better.
Yeah, protruded tongue. If you inspect, you will be able to.
Is there a difficulty in protrusion?
No, sir. No difficulty.
No,
in
sir.
Then why not protrude the tongue and we'll see what the tongue is. And now what we see is there is a tongue on ulcer on the lateral aspect of the tongue. That's what we are able to see here.
Whether there is induration in the tongue.
No, sir. It's just a thick whitish patch was present, sir, which we couldn't move it.
Then we are worried about flora of mouth also.
Yeah, flora of the mouth also. He has mentioned it is normal on palpation. That's like Sunil Sir had rightly told. Tongue is suspicious actually in this way.
Tongue is not normal.
He said it is not indurated.
Yes.
Well, at normal movements, he said bilateral palpation of the mandible. What all things you look for? 4 things you have to look for: tenderness, irregularity, thickening, fracture site. 4 things. Remember, tenderness, thickening, irregularity, fracture site. These 4 things you have to remember when you do a bilateral palpation. 1 finger inside, 1 finger outside. We'll go to the next slide.
Samarth, what are the movements of the TMJ joint that you will look for?
So depression and elevation of lower jaw.
Opening, closing. Opening, closing. Yeah.
Protrusion, retraction of
anterior, posterior retraction. Very good. Yes, protrusion.
Sliding movement.
Lateral. Side to side.
TM joint?
With the help of the little finger and the pulp on the anterior side, we put our finger in the behind the tragus, and then palpate.
It's a joint which is clearly palpable from putting the finger inside. You can always assess the joint very clear properly actually. You can compare both sides. So he said cervical lymph node, cranial nerve. He has told I think why it is relevant or not for completion probably. Why you written for completion probably?
Completion purpose, and if the pharyngeal lymph nodes are involved, or neck lymph nodes are involved, it might be hypoglossal nerve, vagus nerve might be involved. So.
Okay, if it's lymph nodes are involved, yes. Spine is non-tender, parasymphasm absent, all movements are normal. Okay.
When you mention about lymph node, you mentioned bilateral. Lymph nodes are not involved.
Yes.
So we understand that you examine both sides.
Yes. Unless you have to examine both sides. There's a point. There's one point Professor Muthukumaran wants to express. Okay. There's nothing like one side will examine. Always both sides you have to examine. Okay. That's important. So next slide. So anything to comment? It's a lung areas. All the lung areas. What is this lung masses? Very new test, Robin.
Any metastatic lung masses?
No
dull sounds were heard.
Clinical examination, no.
On clinical examination, how did you figure out lung mass is noted?
No dull masses in any of the lobe. I mean, no dulls. No note on percussion.
No. That you tell no note or note, no added sound, changed sound, whatever you call it. But lung mass is clinically your
Reduced breath sounds was.
creating some.
No. The thing is, did you show this presentation to your guide or mentor?
Yes, sir.
Did you show whatever you written to your mentor?
Sir, I have gone through this one. I just purposely kept like that for the.
Because if somebody sees, nobody will permit you to present like this, no?
No. That's what I kept it purposely because they should not do the mistake. I told them, but
Boys, be very careful.
Yeah,
when you
bronchopneumonia itself is a diagnosis. It is not something you see or palpate.
Yes.
Same with lung masses.
You should not
write
bilateral lung air entry normal.
Findings, not your impression.
Air entry normal. I think that is enough. I think. What about
Samarth, do you understand what you are saying?
Yes, sir.
You shouldn't write diagnosis here. You should only write your findings.
Yes, sir.
You can tell effusion is not there. You can tell altered breath sounds are there or not, or breathing is normal. You can tell tracheal deviation, whatever the clinical findings, not lung mass as such. Okay, so just wanted, I kept this one because I didn't change, because just wanted to highlight this one to the whoever viewers. They should not write these things, sir. Sunil sir. So I gone through a slide earlier. I edited a lot of things.
You probably wanted me to intervene.
No, sir, because I did not. I just wanted to put it in the discussion.
Very important thing. No, if you write something like that in the exam, there is a chance of even failure.
That should
because
not.
You don't know basic presentation. How do you examine? That's what comes out. If you write, you can't. There is evidence or no evidence of bronchopneumonia, lung mass.
Just to tell the clinical finding, that is sufficient.
Yeah.
This is very difficult to digest these words. Okay.
Yes.
So next slide.
Okay.
So summary. I think we'll skip and go. We have discussed all those things. Next slide.
Yes, sir.
So diagnostic for A, M0, M0. So what is uncommon in this, Samarth?
So invasion of mandible, sir. No lymph node presence, even though it's a T4.
No lymph node we have discussed. It is still painless. That's what presented as actually ulcer is unnoticed initially. So these are the certain things when uncommon things have to be.
Samarth, I'm not criticizing you, Vishnu. Guys, both of you guys have examined the patient, right? You have.
Yes.
Because like what the senior teachers are asking is the same thing. A T4A with a huge ulcer, swelling, oral cavity is completely involved. It's unusual that even one single lymph node is not there.
Yeah, that's what.
On palpation, we couldn't feel it.
Not okay. Clinically negative. Okay, fine.
That's all the more reason why you must think of another diagnosis.
Yeah, that is the uncommon thing. Lymph nodes were not there clinically, Robin. I have examined.
Yes. Okay, sir. No problem.
Is it necessary, sir? Last two sentences.
Which one, sir?
Last depth of invasion.
That is not necessary.
He said to be assessed by imaging, depth of invasion and that is to be assessed by the imaging. That is not in the
last name.
No, we should have come into the presentation.
Yeah, that is for the investigation or assessment or discussion it comes.
No, that should be mentioned only if you are asked about it. That will show your depth of knowledge.
Yeah, currently, of course, you are at external extension is the most important thing, but that will not come under the provisional diagnosis. Okay.
No, in the present new classification, all these things have been included. Doesn't mean you should write it down in the history or physical exams.
Yeah.
Or even in the diagnosis.
Can he add as squamous cell carcinoma, sir? Typical presentation. Also proliferative, HSA, and all those things.
Later he can tell probably squamous cell carcinoma. DOI and external extension should not be added in the diagnosis. Of course, he has written has to be assessed by imaging. So it should come in the investigation actually.
Yes.
Like he has mentioned that in the imaging, but better to put it in the investigation rather than in the provisional diagnosis. You can tell probably squamous cell carcinoma.
Yes.
Okay.
So we'll proceed to how you evaluate this patient.
So we would first want to start with To confirm the presence of malignancy, we would like to get a wedge biopsy from the ulcer. Wedge biopsy, we need two samples from two sides.
Wait a moment. Would you like to do some imaging first, or you would like to straight away go for biopsy? Because there was a confusion here saying is it carcinoma cheek going on to bone or bone going on to cheek or the mucosa. So would you want to do an imaging first? Generally, it is like that, no?
Generally,
Imaging is after non-invasive investigation in general everywhere.
But in usual teaching is in oral cancer. First
I know, sir. I know, but here there is a problem. It may not be oral cancer.
Here, absolutely right, sir. You have to do imaging because you are still not sure because of the total so many.
Yeah,
things.
the general rules apply everywhere, and particularly in this case, where there is every chance that it may not be oral malignancy.
You should
It
go
means
first and then
carcinoma.
biopsy. You should go in the reverse order. First imaging and then biopsy. Absolutely right. Okay, this is right. Agreed. Why wedge biopsy you want to do?
To confirm the presence of malignancy, we want the sample from the edge of the ulcer, sir, because the center of the ulcer contains necrotic tissue and is not cannot be evaluated properly over there. And
why you wrote CCT and MRI both? Is it both is complementary to each other, or you want to?
No, sir. CCT to check for invasion into the mandible, and MRI if we want to see if the presence of lymph nodes is positive or not.
Apart from lymph node, for the mandible, is there any use of MRI over CT scan? Can MRI detect something which a CT scan may not be able to detect?
So MRI will be useful in assessing if there is any growth or if there is invasion into any soft tissues or any.
I'm talking about bone. I'm asking you about bone only.
Yeah, sir has already said lymph node, soft tissue. Okay, chalo. Anything
else? Patient, you are saying it's fixed bone. So will MRI and CT give different findings, or tell you different aspects of the tumor invasion into the bone? That's a question. Now, the CCT will give you a better idea regarding the cortical involvement. The MRI will give you a better idea regarding the marrow involvement.
Marrow involvement, yeah.
Okay.
Okay.
That's the important point, I think. Yeah.
But then generally, at least in India, you shouldn't be doing both unless there is a specific reason.
Yes.
Yes.
Yes, sir. But most of the time,
now, is it necessary to write all these things down? Suppose you're going to do CT scan, would you want to do orthopentagram? Unless, very advanced disease like this.
Orthopentagram is not necessary actually. That is the old method. Mainly CCT. Most important is CCT. MRI may be complementary to a certain extent to assess other areas.
Soft tissue, perineal.
Yeah, especially floor of mouth. MRI is very useful because you want to know the depth of invasion, all that.
All those things MRI is useful. That's what it's
yeah.
Why you have mentioned incisional biopsy?
Incisional biopsy to confirm the presence of malignancy.
Incision from where?
From the edge of the ulcer, sir.
Oh, wedge biopsy. Wedge biopsy. Wedge or edge biopsy.
We want to see the normal tissue as well as the cancerous tissue and to see
No, Samarth, you didn't get, sir. What sir is asking is you put incisional or wedge biopsy. Sir's question is, why are you doing incisional biopsy and from where? Where will you start?
You put it first.
Yeah, that is very, very, I think it's there in the book also. We know wedge or edge biopsy, okay. What you said, the reasons are correct. But incisional?
I'm not sure, sir. It is. I studied.
Tell me, do you know what is wedge biopsy? What is incisional biopsy?
Incisional biopsy, we take we incise and take the contents of the mass of the cancerous lesion. And
what is edge
biopsy?
When the lesion is exposed, what will you take? When the lesion is already exposed, no?
Yes.
Yes.
So where is the question of incision?
Yes.
If the lesion is inside in the depth.
In soft tissue tumor, we do incision biopsy. Understood? No.
Yes, sir.
where you have to go in, make an incision.
The lesion is not exposed, you will do an incisional biopsy. When the lesion is already exposed, it is in front of you, no?
Yeah.
Say, suppose soft tissue sarcoma of extremities, suppose repeated biopsies are not useful, then you can put an incision. Big soft tissue sarcoma, you go into the depth, you can take a tissue for confirmatory diagnosis. That is incisional biopsy. You make an incision over the skin and taking biopsy. Here, as Sir said, already exposed. You cannot use the word incisional. You can remove that word, otherwise it is correct. Which biopsy is correct. That includes edge.
So understood, no, Samarth, that what's the difference between indications of meaning of incision biopsy and wedge biopsy? Understood, no?
Yes, I understand.
Yes, sir.
Clear, no confusion. Professor Keshav has told very clearly. Is it clear? Okay.
Yes, sir.
Yes.
Vishnu? Okay.
Yes.
So we'll go to the treatment, Robin.
Yes, sir. Yes, sir.
Again, Sunil sir is rightly told here image should come first and then biopsy. Of course, as for undergraduate, there is some chronology, biopsy, then pathological diagnosis, then imaging, like that. Otherwise, in this patient specifically, that is the order which is required. That point is very clear.
Yes.
We have discussed properly. Next slide. Treatment. What treatment?
Since it is a T4 cancer, we would like to first try out neoadjuvant chemotherapy and radiotherapy to see if the tumor shrinks, and then we operate it. And we, on the assessment, we confirm whether it is shrunk or not. And then in surgical management, we go for wide local excision. And since the involvement of mandible is seen, extensive involvement, we want to have left hemimandibulectomy. Plus, if lymph nodes are there, we do radical neck dissection and reconstruction by flap.
This is a very.
Biopsy. Have you got the biopsy? I don't know whether I didn't see or it is.
Yes, sir. I've seen it is squamous cell carcinoma of left.
It's a squamous cell carcinoma.
Yes.
Okay.
Okay.
This.
But even the ultrasound or MRI, CT, nothing has revealed the lymph nodes in the neck.
So in CT report, there's mentioned that small lymph nodes are present in the submandibular region.
Probably reactive.
Reactive lymph nodes are present.
Probably reactive.
Not suggestive of these CT features are not suggestive of nodal involvement. That's what they have written in the report.
Yes, sir.
Yes, sir. So neoadjuvant is probably correct, I think, with the chemotherapy and radiotherapy, usually 3 to. Now they give short cycle high dose radiotherapy. I have seen many radiotherapy or onco team, they advise that one, but it has got its own drawbacks, complications also there I have seen. And of course, reassessment later, they usually advise to have some 3 to 6 weeks gap to go in for the eventual surgical resection of these tumors. And neck dissection, of course, we have add on to whether to MRND or because T4 lesion. There is a controversy because we need to be quite aggressive when it is because T4 lesion.
At least you tell us what is the difference between radical and modified radical.
So in modified radical, we try to save either of sternocleidomastoid, internal jugular vein, or spinal accessory nerve. But in radical, we remove all those three.
Okay. In this particular case, where there is no lymph node involvement, do you think that it is necessary to do a radical neck dissection? Because the IJV, the sternocleidomastoid, as well as the spinal accessory, they are quite unlikely to be involved directly by the tumor because there is no lymph node involvement. Then on what basis do you want to do radical neck dissection? The controversy is there when there are lymph nodes. There are no lymph nodes. Even CT doesn't show lymph nodes.
Yeah.
Then why do you want to do radical?
Samarth, you can give justification like if it is high grade tumors and like that.
But it is not high grade also in this case. What is the grade?
T4A.
No, it is I remember as a high grade, sir. I can't recollect.
Generally, high grade tumors, do not grow to large size because even they're very small, they spread to lymph nodes and they're spread to distant sites. No?
But there are a lot of uncommon things in this patient.
Another thing is, is it okay? Can we do a segmental mandibulectomy in this case? Is it always necessary to do left hemimandibular buccal? Because the tumor length is 4 centimeter, I understand. But then you said inside the induration is only 1.1 centimeter, half centimeter, something like that.
That's a lesion inside the ulcer, but mandible is very.
Yeah, but okay. But then how far it is from the angle of mandible?
That's an individual decision, sir. Segmental and.
No, the essential thing is that we must get a margin-free excision.
Yeah, margin-free excision for the
mandible.
mandible.
Yeah, so,
wide local excision, I think we can say as a three-dimensional wide local excision.
Three-dimensional.
So that will be
yeah,
complex.
because nowadays all the cancer surgery is going in for function preserving. Left hemimandibulectomy is very difficult to reconstruct.
Segmental mandibulectomy with the reconstruction. With the plate.
Yeah, quite possible to reconstruct in both ways, both free flap as well as by steel plates. But then you shouldn't be giving radiotherapy. That's the issue.
Yes.
In the exam, better to tell segmental mandibulectomy.
Yeah, that's it. Because as far as you think that the angle of mandible is not involved and you are able to get a margin, you can fix appliance there to some plate and screw things which OMFS people will come and help.
That's true.
Then,
sir, R&D they can tell, sir, because T4 lesion based on the grading definitely R&D can be, because in our setup very difficult to go ahead later because of so many other reasons.
But I don't know, sir. If the lymph nodes are not there, how can you justify R&D?
The current treatment for R0 neck would be a supraomohyoid dissection. One level more than what? So if it
more
is
than what? This one.
yes.
But then the level of invasion also matters, sir. If the level of invasion is more than
depth of invasion and grading. These two things are.
Yeah, I'm sorry, not level, but the thickness, depth of invasion.
Depth of invasion and grading. These are the deciding factors.
Yeah, that also makes.
Neoadjuvant definitely right. Reassessment, then wide local excision, segmental hemilectomy, MR&D bar R&D.
Again, neoadjuvant radiotherapy, I am not sure. In this case, especially mandible is there.
Mainly chemo, sir. But here now many people, oncologists, they decide everything. You are only doing after this.
But that's the one which can lead to osteoradial necrosis, which we are, like Robin was saying, we used to see lots earlier. Now it's less commonly seen all that.
Adjuvant chemo, assessment, wide local excision, segmental excision, R&D bar MR&D, reconstruction, of course. Whatever free flap with the.
So in general, R&D becomes an option, because most of the time such patients will have at least N2 or N3 nodes. But here the things are different.
Yes, sir.
Yes.
Yeah.
So that is why just before conclude, I'll just pick 5-minute slides, sir. My slides.
Yes.
So just meantime and switch over the slides. Just comments about their they presented well, but a lot of few things are gone mistake. Lung mass is wrong. And skin involvement, hardness, consistency.
You must also know something about the flaps which are being used in oral malignancy, because it's such a large lesion, wide local excision, mandibulectomy. What are the flaps which can be used here?
So either local flaps like nasolabial or regional flaps like pectoralis, major myocutaneous flap, which is most commonly used. And for bone reconstruction, we can use either free fibula flap or even rib flaps can be used.
Switch over to my slides.
Actually, it is not the pectoralis major. It's not the most commonly used. Especially in a large lesion like this, you always need to do a free flap, because you can bring in the bone as well. Yeah, bone. Large defects like this, you can't do it with pectoralis major alone.
Yes.
And
is a free flap with the fibula or radial forearm flap. Of course.
Yeah. Either using the fibula or the radius. Both of them are equally good.
You have to do a plating for the reconstruction of the mandible. So,
yeah, local flap rotation, all those things are not useful in large lesions.
Just comments, Robin, start with your comments. What exactly their presentation is a difficult case actually.
Yes,
but we are not discussing.
Oral malignancy is a difficult one for both UG and PG.
Sir, I think Vishnu and Samarth have done a great job, because as Sunil Sir said, this is not a easy case for undergraduates.
Yeah,
Even postgraduates will sweat a lot. But they have done very well. They have covered all the points. But boys, be very careful when you present such a beautiful case, because it's a huge swelling with multiple ulcers, multiple findings in the oral cavity. Everything else was fine, but please try to not avoid words like it appears normal. Tongue appears normal? Absolutely not. You've seen that 4 or 5 of your examiners have seen that it is not seen. It's abnormal. So please mention something. It's a patient. Just say what is wrong. Just don't say apparently normal. It means as though that we are not sure what it is. So be careful. But otherwise, your presentation is good. You've covered. In fact, you've answered all the questions. When it comes to this sort of a case, like sir will be rushing us through the slide, oral cavity is not very easy. Investigations are clear-cut general principles for all the cases we know. We start off with imaging, like sir has said, because we should know where it's going. FNAC of lymph node if it is present, biopsy, imaging. These are the classic principles we have for investigations for oral cavity. The management is very tricky. I have read Bailey and Sebastian, which are very heavy books. SRB Sir's book is the easiest I've read for this, because there are 10 different patterns of patients who present with this in oral cavity. You have early, you have advanced, you have early without lymph node, with bony involvement, without bony involvement. So all of them have different modalities of treatment, like what Sunil Sir had just mentioned. So please read that for the exam. I think you should write it separately in a page, so it's easy to know, because you have cesium and iridium needles which are recently being implanted into the cavity instead of doing before we do the wide local excision for early without involvement. So it's very easy without osteoradionecrosis. So it's very nice. And like sir has mentioned, you should know the bony substitutes and the flaps.
Yes.
You should at least for undergraduate, you should know 3 for each. The most common, like sir has already mentioned, that osteocutaneous myo flap is very important. Okay, the radial or the fibular flap, the rib, the third one. That's it. The steel and the metal plates, you can keep it last, because when we check your answer sheet and see Viva for you will be 15 to 20 minutes. This case is very difficult, but you have done a great job. Yes, absolutely good. Yes.
Thank you, sir.
Yeah, you've done well, but the only thing is you need more of reading. You must read standard textbook and not guides and things like that. Otherwise, you will end up answering in a very wrong way, because now most of these, unlike earlier days when Jalsa used to do, most of these things are being managed by oral, onco surgeons and people like that. So the current thing is to go by free flaps most of the time. So that is there in your textbook, Sebastian and Bailey.
Yes.
Don't need to have very high books also. But then you must read the management when you come and present cases. But otherwise, quite good.
And it's a difficult case, of course. Like Sunil Sir told.
Yeah, it is difficult. It is difficult.
Planning strategy is based on the clinical and imaging and biopsy. All 3 components helps you to decide what exactly it is. How exactly go ahead, because individual case, that's why Robin told different pattern, different approaches and expressions should be there. That's the point which you have to remember.
Robin has already thanked us, sir.
Yeah, yes, true.
So it's time to wind up.
Sir, I'll just quickly go through the slides, 5 minutes, then you will conclude this one. So next slides. So just Robin had told oral cavity anatomy should be known. That's what I just mentioned here. I'm not detailing it. Next slide. That's the first thing Robin told. So this is a different, next slide. This is a different images, just want to show carcinoma cheek, how tongue entirely involved with ankylosing. Next slide. So again, lip carcinoma, palatal growth, how exactly it looks. Next slide. So history, age, occupation, residence, everything you have to look for. Next slide. You can see the tongue tie here and ulcerations here. Flex lip, other things are congenital entity, mucosity, you have to remember. Next slide. Next, sex is important, and of course, mainly common in males. That's why it is oral is very common in males. Occupation, there are so many names are there, like countryman's lip, other things. You can always go through the book. Next slide. Address, because Australian guys are common. Why it is again place where they come out important. Next slide. Next. Next. History of ulcer in the mouth. This is what its chronology is usually like this. Next, pain in the ulcer, difficult opening the mouth, swelling in the mouth. Swelling in the neck in benign condition. I said swelling in the neck is important. Lymph node involvement. That was not there in this patient. So I'm not going to detail it, but this table helps you to understand swelling, ulcer, swelling, pain, fever, salivation. We have discussed all these things. Protrusional tongue, trismus, past history, females, of course, menstrual history, other things. So just a table is important to take the histories. Next slide. Next slide. So etiology, we have discussed all these 6 X's. Human papillomavirus, again, we have discussed again these are the things. Next slide, you have to remember. All these 6 components also Robin has discussed. Next slide. So inspection, you should have a torch and the tongue depressor to inspect properly. That's what exactly I'm showing. So entire oral cavity should be inspected properly. Next slide. Order is also there. I'm not going to detail it. Next slide. So inspection, this is the order exactly you have to look for. Ulcer, this one, lip, everything should look for. Lip, cheek, teeth, gums, tongue, palate, tonsils, fauces, and look for and all. If there's ulcer, in detail about the ulcer. So next slide. And this is for congenital ulcer lesion. See that after ulcer is there. So exactly it looks like. Next slide. So lip, you can see lip lesions, edema, hemangioma, ulceration, stomatitis, cheilitis, different things you can do. How that it looks like. Next slide. Next is the mucus system. It's very common actually, not uncommon. Next slide. So this is how exactly examine him properly. That's what Sunil Sir and Muthukumaran Sir, Robin and Manoharan Sir have actually told. Examine properly. It takes time. You should take time to examine. You can see the leukoplakia there. You can see the leukoplakia very clearly here. Mucus you can see in the cheek. How exactly leukoplakia looks like. You can see the submucosal fibrosis, a band like here. You can see that. Erythroplakia also you can see. Next slide. So this is the tongue. When you examine this anatomy, you should remember actually. That's what again I think somebody has discussed during Robin or somebody, Sunil Sir or Muthukumaran Sir told that hemangioma, tongue polyp, papilloma, the tongue is not uncommon. Remember, it may turn into malignancy. That's the point which I remember. Next slide. Next, again, tongue deviation in hypoglossal nerve palsy towards the same side. Tongue examination, wasting and deviation also you have to look for, other than ankylosing. Next slide. Carcinoma ulcer is common lateral margin. Fluorothymous ulcer, you can see that. This is the lift the tongue up and then see the ventral aspect of the tongue actually. Next slide. So inspection again, tongue depressed properly, examine properly. You can see in this other slide, you can see the tonsillar malignancy. Next slide. So this is exactly all these things has to be highlighted. Retromolar trigone. See, this is the retromolar trigone, the blue colored one. So that's already defined. You should know that something about retromolar. You can read it out. So inspect and palpate. Trismus. Next slide. So what exactly it is? Grading told. I'm not detailing about this. Why this happens? We have discussed again. Dental infection, fibrosis, and malignancy. How to check also like this. That's how we discussed. Right. Next. Next. So this is again in the orderly you have to palpate. Lip, cheek, gum, teeth, tongue, posterior of the tongue. There is separate method to examine posterior of the tongue from behind. Fluorothymous, palate, tonsils. Again, thickening, tenderness, fracture site, irregularity. The 4 things to remember when you palpate the mandible. Ulcer fixation, we have discussed those things. Like the lymph nodes, both sides. Remember, Sir has told, not one side, both sides you have to examine. Next slide. So this is bidigital palpation of the mandible. See that. Look for 4 findings: irregularity, fracture, thickening, tenderness. Next slide. So the characteristic tongue should be inside when you palpate for induration, not outside. You can remember this one always. You can see the look for the protrusion, all the other things, but the palpation should be tongue should be inside. Next slide. This is how it permanent. Go back. This is how exactly examine the posterior third. They're very important. You be there behind, and your other finger should put like this. Otherwise, you'll bite your fingers. This is how exactly posterior third of the tongue should be palpated from behind, hugging the patient. Next slide. So this is again shown properly how to look for posterior third of the tongue. It's a very important clinical method. Next slide. So again, fluorothymous palpation, very important. Next slide. Next. This is the again, you can see the tonsillar fossa. You can see the tonsillar swelling here. Both this one. So use the tongue depressor properly to inspect, and proper light source also important. Sometimes in a headlight will be very, very useful to focus on the posterior tongue tonsils. Next slide. And again, this is the orderly fashion: lip, upper lip, lower lip, buccal mucosa exam, palpation, posterior inspection, and palpation throughout the mouth, palate, all those in the orderly fashion. You should do that. Next slide. And neck lymph node, both sides you should examine. One side first and other side. Level 1A, 1B, 2, 3, 4, 5. This is the order. One side first and other side next. So this is exactly mentioned there. Remember all these things: alcohol abuse, smoking, everything we have discussed. Losing of teeth, tooth extraction. That's important. Same area of the extraction is done. That's the duration profile. That's what again ulceration, ear pain we have discussed, swallowing, mouth opening, protrusion tongue, bone pain in the mandible and maxilla. Sarah discussed in maxilla. Halitosis again, why it is very discussed. Salivation we have discussed. Next slide. And again, inspection at trismus ankle was important. Tenderness, posterior transfer fossa, mandible palpation, lymph node exam, respiratory system. Examinations, not for the lung mass. Don't write lung mass. That's very clearly highlighted. Next slide. Nice. Investigations again, wedge biopsy. We have discussed why not incision biopsy. Remember, this is the not orthodox old thing, but CT scan is the important thing. Definition of the lymph node, phonological guidance, maybe if it's so. Never do lymph node biopsy. That's important. Don't ever tell lymph node biopsy. Essential blood and triple endoscopy. Other examination, respiratory system. Next slide. Next slide. This should have come before that. Next slide. Next. So cheek, tongue, teeth lesions. We have discussed all the evaluation, treatment, neoadjuvant surgery, reconstruction. Sir has already told. Pre-flap is the good standard now. So again, remember proper history, weight like the mandible, neck lymph node system, clinical staging, surgery, chemotherapy, radiotherapy, neoadjuvant reconstruction. We have discussed that free flap is most important. Of course, other things you should know: PMF flap, forehead flap, delta fetal flap, but whether it's cutaneous or myocutaneous, definitely will be asked in the exams. In a small setup, do not do the free flap, then you have to do PMF flap, forehead, and other things as far as depending on the requirement and situations. So this is the basic thing about the oral malignancy. Again, I request my book, methods, operative surgery is there, manual is there. So you can always refer all these books and get everything about those things. And my website is free. You can learn surgery. Daily MCQs are coming. You can go through it and put answer for that. And once a week now lectures are there. So many lectures already there since last 1 year. I've been doing that. And live sessions request once in 2 weeks we have planned. Robin and myself planned it, and eventually, immediately within a month, Manoharan Sir has joined in the last 1 year for my live sessions. So different aspect, because oral cancer we never discussed. So please again request all students who are on join our live session for 1.5 hours. Usually it is. There's a lot of information, not only mine, but of course professors like Muthukumaran, Sunil Sir, Robin, Manoharan Sir is always giving some hints, and Robin is very good in clinical approaches and analysis also. Always it is very, very informative, all these discussions. You can always go through our previous live sessions there in the website. And all my lectures, around 350 lectures, are small lectures are there. You can always go through that. And daily MCQs are there. You can attempt to have this one. So please go through my website, subscribe and share with your friends, and daily see it because it's free. You can learn instead of watching something else. You can learn surgery on daily few minutes basis, so that you can definitely make surgery in a better, easy way of learning. Again, thank Sunil Sir for joining. Thank you, sir, very much. And Muthukumaran,
Thank you.
I know he's
Thank you, sir.
Thank you, sir. All HOD, Manoharan Sir, my guide or something. I am really
Thank you, Sunil sir.
very encouraging person for me actually. Robin
Thank you, sir.
is with me.
Thank you,
For all
Sunil
my
sir, Muthukumaran sir, Robin. Nice meeting you after a long time.
Robin,
Yes, sir,
thank you very much for joining and spending time with me.
Both options very well.
Of course, Samarth and Vishnu presented
Vishnu,
very
yes.
well. Had a good,
Yes.
a difficult case like Sunil sir told, but many things to learn from this. There are a lot of things to learn. So again, thank you, sir, for joining. Muthukumaran sir, Sunil sir, Robin. Manoharan Sir, thank you. Probably after 2 weeks, we'll have a live session on what discuss with the admin, what exactly it is. Thank you, students. Thank you, everybody. And
Muthu sir, we are meeting for the first time. Thank you very much.
Thank you, sir. Thank you, sir. Thank you, Ravi sir. Thank you,
Thank you very much.
Thank you, Manoharan. Thank you, SRB sir, for the opportunity.
Because of we are celebrating National Surgeons Week from Kashmir to Kanyakumari for past 15 days. Sunil sir is really tired. He's our president also this time.
yeah,
Yeah,
this is,
so we have been running around every day. He's really tired.
this week actually, this week. So
Yeah, every day. Tomorrow he has OT also.
Live session. And
Nice
thank you,
session.
Keshav Prasad joined. Like, Thavala joined actually, I don't know, he joined through YouTube, I think. He joined to the Google link. Thavala, thank you very much. He's in UK actually. He was my student. Now he's working in UK. Actually, he regularly joins. Thank you very much, Thavala. Thank you, Keshav. Thank you, everybody, sir. Thank you very much for joining.
Thank you. Adi, thank you very much. Thank you. Yeah.
Vishnu, Samarth, all the best. You present all the best.
Thank you, sir.
Thank you, sir.
Thank you. Good night.
Thank you, sir.
Thank you, students.
Thank you, sir. Good night, sir.
Thank you, sir.
Good night.
Good night.
Good night.